Good afternoon, and thank you for attending Understanding Disability, Healthcare Barriers and Disparities. This presentation is a part of the Ohio State University College of Public Health Alumni Society's Diversity Lecture Series. The Society is excited to have Maria Matzik present this important topic. Maria Matzik is a proud disabled woman and has been a disability rights advocate at the local, state, and national levels for over 25 years. Maria is a graduate of Wright State University with a bachelor's degree in rehabilitation counseling and currently serves as the Education and Advocacy Specialist at the Access Center for Independent Living in Dayton, Ohio. Quick housekeeping note, please type any questions that you have into the chat. We will take a couple of breaks throughout the presentation to discuss your questions. Thank you.
Hi, everybody. Thanks, Zeb, for that great introduction. I appreciate it. I'm going to get my PowerPoint pulled up. All right. So I appreciate everybody coming today. So I want to start with telling you a little bit about who I am. I think it's important that people get to know individuals, especially when we're talking about dealing with medical issues. I don't think anybody ever really takes the time to get to know their patients or their clients or the people that they're treating. So I'm going to take some time and tell you about me. So as Zeb said, I consider myself to be a disabled woman. A lot of people will emphasize person first language, person with a disability. But for me, truly, my disability is a big part of my identity. It's how I have developed my life, my lifestyle, and everything that I've done in my life is because of, not in spite of, my disability. I'm a disability rights advocate, and I have been an advocate for 25 years in the state of Ohio, but for my entire life, I've been an advocate for myself and my needs. I identify as CRIP in the disability community. Disability is a culture. And a lot of us who are proud to be disabled identify as Crips. It's part of our community, part of who we belong to. I have a wonderful life partner who I've been with for 25 years. And we share our home, our life. We have 5 beautiful cats. I identify as she, her, hers. I think it's important that people understand how individuals perceive themselves and how they want others to perceive them. And then I have many great friendships. Hopefully, a lot of those friends are listening today. And I think it's important to say, because I don't think that a lot of people recognize individuals with disabilities as employees, as employers, as homeowners, and as taxpayers. So I wanted to make sure to say that and let you know that's a part of my identity. I wanted to give you a quick image of my life. This is our backyard. This is my partner and I walking in the woods. This is us enjoying Halloween. And on the left, this is me at a budget protest at our state capitol. And I think it's important that you see people with disabilities in all aspects of society and life. So, what's my story? So, the reason that I feel so passionate about talking to all of you today and doing presentations like this is that I have experienced a lot of segregation, a lot of stereotypes, and a lot of unjust situations just on the basis of my disability. So, my medical history, I have muscular dystrophy, specifically spinal muscular atrophy type 2. I was not diagnosed with that. I was diagnosed with type 1, which at that time, in 1971, that was considered to be terminal. When I was diagnosed, my mother received a phone call from the doctor saying, I'm not really sure what your daughter has, but I know that your daughter is going to die. So it's important to take your daughter home, keep her safe, love her, and enjoy the time that you have with her. So we weren't given a lot of options at that point. We were told I would die by the age of 2 years old. When that didn't happen, my mother started to look for some other options for treatment for me. Along the way, she was a devout Catholic, so she put all of her faith in higher powers for a miracle. Now, I tell you this to get a snapshot of what it was like for me and millions of people with disabilities. When we're diagnosed, especially with a diagnosis that isn't common at the time, or that doctors aren't yet familiar with, or still doing research about, we become a piece of education. We are there to educate the medical professionals about our condition and about what will happen with our condition. So that's what happened with me. I was taken to the University of Pennsylvania Hospital and I began my journey with the Muscular Dystrophy Association. I learned from a very, very young age that I was perceived as different and abnormal. Another thing I want to tell you, because I think it's important never to underestimate the intelligence of a young child. I have my first memory from 7 months old. I remember vividly being in the hospital after having my first muscle biopsy and being in a crib and my mother not being there. I remember the taste of apple juice, which I hate till today. I remember the smell of Johnson's baby soap, which I hate till today. I was terrified at 7 months old, and I was alone in that crib, and nobody was coming up to me to give me any kind of attention or or affection. I just felt alone. So I just want you to think about the fact that when we treat people, especially children, babies, young adults, or people with lower intelligence, or at least perceived to have lower intelligence, there's probably a lot more that they are absorbing than what you give them credit for. My experience went on to the age of about 8 or 9 years old when we stopped going to the University of Pennsylvania. The reason why is that the doctors were basically just challenging my brain. They were doing nothing for my body, my disability, or my development. We later found out that they were just trying to figure out if muscular dystrophy affects the brain as well as the body. We stopped going there, and I started seeing just a regular general practitioner. At that time, I was starting to grow, and my scoliosis, which was the curvature of my spine, was becoming pretty severe, and it was starting to affect my health and my ability to breathe. Now, I didn't notice this because you adapt to changes. You adapt to how your body changes over time. And so I wasn't aware that I was having the difficulty with breathing that I was. At that point, my family doctor had treated me for pneumonia about 3 different times. And this was over a course of about 4 years. So at the age of 13 going on 14, he recommended the Alfred I. DuPont Institute, which is part of the Nemours Foundation in Wilmington, Delaware. We had never heard of them, but we went ahead and pursued going to this hospital. At the beginning, I will admit I was quite skeptical about how they would treat me, but this was probably the best decision that I had ever made, was to receive treatment from that hospital. Now, I'm not going to say that it was easy and that it didn't come without any hiccups. It came with plenty. But I had a great team of people to help me through that. During this time, I was also growing as a teenager. So a lot of things were changing for me. I was dealing with all the same things that teenagers do. And then dealing with some life-changing decisions we had to make. my scoliosis had gotten to the point that I had 10% breathing capacity. It was time to decide to do a spinal fusion to save my life. I found out during the hospital stay that I was misdiagnosed when I was 1 year old and that I did not have a terminal form of muscular dystrophy, that I had spinal muscular atrophy type 2. I also found out that the surgery I was about to have could have been done at a much younger age and probably could have given me more quality to my life. But that didn't happen. So here I was to make this decision about should I have the spinal fusion and what would my life look like. I had a psychologist and a teacher who were instrumental in my ability to make judgments and make decisions about my life and my medical care. I say this because it's important to understand that when we talk about a team approach, we're not just talking about doctors and nurses, but there's a lot of other people that play into a support system for individuals. I had overheard prior to me having the spinal fusion, my team of doctors talking about the procedure that they were about to do on me. They were not just talking about it, they were arguing about it. They were disagreeing with each other and telling each other why they thought the other doctor was wrong and what their decision would be. At that point, I decided I'm not having the surgery, and I called it off. Now, the hospital I was at was a teaching hospital, which means that my surgeon would come in at 5 o'clock in the morning with probably 8 to 10 residents. He would turn the light on, he would uncover me, and he would begin to explain to the residents about my different anomalies. He didn't talk to me as a person. They didn't acknowledge me as a human being. I was a specimen. I was somebody who was going to teach them. This happened every day. So when I heard this discussion and I called the surgery off, I was told by the resident, well, you can't do that. You're just a child. I was 15 years old. He said, you can't understand what you heard. I said, I can, and I did. And what I'm going to tell you is I would rather die than let you touch me. And furthermore, I said, if you don't know what the hell you're going to do to me when I'm not on that table, what will you do to me when you have my back opened? What decision will you make? You're all arguing right here, and I'm sitting right here listening to you. And you didn't even acknowledge that I was in the same room. That started my assertiveness. That started my belief to know that I had the right to say yes or no to what was going to happen to me and how it was going to happen. From that day on, my surgeon explained everything. He took me into the operating room before my surgery. He showed me everything that would be done to me and every machine that I would be on. We trained nurses of how to move me safely when I'd be unable to talk. And it was just a great experience to be able to have that relationship and communication with my team. Now, there were still glitches, there were still hiccups during my surgery. My knee was broke. Nobody believed my mother when she told them something was wrong. There were many other issues that happened along the way, but overall, that experience brought me to where I am today. Later on, I had an experience with a local hospital in Pennsylvania, which is where I was from. I went in because I had a flu shot. I reacted to the flu shot. And then later I got a respiratory um, cold, essentially, that turned into respiratory failure. So I went into the hospital, and the first thing they asked is what were my, or did I have advanced directives? I didn't know what that was. They explained to me what it was. And I said, well, if you mean, do I want to be coded if I stop breathing? Yes, I don't want to die. I was 20 years old. I'm sorry, 23 years old. They told me that it didn't matter what my advanced directives said, that because of my disability, I had no quality to my life and they would not code me. So I entered a dire situation, knowing that if something happened and my heart stopped, that I would not be resuscitated. That is not just situations that happened in the past. I recently dealt with an issue with my tracheostomy. I sought out the care of an ENT, and I was treated as though I didn't know what I was talking about, that he didn't have time for me. He was completely oblivious to the fact that my ventilator is necessary, and he instructed my nurse to turn that thing off. My nurse looked at him and said, what? And I looked at him and said, my ventilator? And he said, I don't want that beeping when I'm doing the procedure. I had been battling, trying to get the right accommodations for simple things like an ultrasound. When I went for the trach procedure, I said, I need to have a bed. I can't be positioned in my wheelchair and I can't be transferred onto a table. I need a bed. You would have thought that I was asking for a plate of gold. No facility can accommodate a simple thing like a bed. So you might ask, why do I advocate? This is why I advocate for myself, for others. I want to read this to you. This is something that stuck with me through my independent living training. A little history worth knowing. You can Google this, there's a lot more information. This is factual. The United States Supreme Court, in an opinion by Justice Oliver Wendell Holmes, upholding the constitutionality of a Virginia law authorizing the involuntary sterilization of disabled persons, ratified the view of disabled persons as a menace. Justice Holmes just opposed the country's best citizens, non-disabled persons, with those who sap the strength of the state, disabled persons, and to avoid being swamped with incompetence, ruled it is better for all of the world if instead of waiting to execute degenerate offspring for crime or to let them starve for their imbecility, society can prevent those who are more manifestly unfit from continuing their kind. This is why I advocate. So now let's talk about facts. So there are over a billion people, which is about 15% of, sorry, I got to move the camera, of the world's population that have some form of disability. Between 110 million and 190 million adults have significant disabilities. Rates of disability are increasing due to population aging, increase in chronic health conditions, and we'll see a big increase after this pandemic. And 1 in 5 Americans is a person with a disability. Disability is a natural part of human existence. Disability can occur at any point in our life. The World Health Organization recognizes that what defines individuals with disabilities, their abilities, and their health outcomes more often depends on their community, including social and environmental circumstances. So when we think about and talk about individuals as rare, I've had people say to me, but you're unique. This is rare. This is not rare. You don't see this because society is still not accommodating for various disabilities. And the medical world certainly is not. The World Health Organization defines disability as a functional concept. Disability is any long-term limitation in activity resulting from a condition or health problem. People with disabilities are a diverse group who share the experience of living with significant limitations in functioning as a result of and often experience exclusion from full participation in their communities. A diagnosis of a disability should never define us, our talents, our abilities, or health behaviors and health status. So here, I want you to look at 2 diagrams. On the left, this is what we call in the disability world the medical model, that the impairment is the problem. And you see we have doctors, specialists, social workers, surgeons. We go to special schools. We have special training centers, occupational therapy, physical therapy, sheltered workshops. On the right, we like to think of this as the independent living model. This is where we say that the structure within society or the environment is the problem. The world is inaccessible to most disabilities. There is a strong belief in the medical model. People are kept at a poverty level because if they earn too much, they lose their benefits. There's discrimination in education, in employment. Environment is inaccessible. There's prejudice. So again, the medical model of disability focuses on the lack of capacity to function. The emphasis is on the impairment. The impairment or the biological structure. Any intervention is an approach from an individual's medical perspective with outcomes focused on health and illness. In the social model, what makes someone disabled is their medical condition, is not their medical condition, I apologize, but the attitudes and structures of society. In the independent living or social model, we take a civil rights approach to disability. Society is what disables us. We focus on improving our quality of life, not our condition. And people with disabilities have less access to healthcare services and therefore experience the unmet healthcare needs that we've been talking about. So I want to take a pause, and the reason I'm doing this is I think it's important for everyone to realize that everyone takes information in differently and processes it differently. And so when we deal with people with various disabilities, we have to be mindful that there needs to be a pause to answer questions, to explain things that were unclear, or just to have a dialogue. So I'm going to stop now and take any questions or clarify anything.
Thank you, Maria. One of the questions that we have in the chat is, can you describe in more detail how accessible your regular medical checkups are now and how inaccessible your medical providers were in the past? Things like examination tables, mammograms, diagnostics, dental exams, etc.
Yes, absolutely. Thank you for that. Actually, the accessibility when I was at the Alfred I. DuPont Institute was phenomenal. They could do anything without causing bodily harm to the individual. And I emphasize that because a lot of people don't think about the different positions that you have to be put in for various medical tests or exams. And it's not always possible for a person with limited movement to be put in those positions safely or without causing injury. So currently, for me and for many people who I know with physical disabilities, the accessibility in offices, it's terrible. I have not had a full exam probably since I was at DuPont. I had a visiting physician several years ago that was able to order in-home ultrasounds, which was great because I could be in my bed and my caregiver who knows my needs could position me properly. With the way insurance is, that's no longer the case. And an ultrasound was the only way that I could actually have a breast examination. I've not been able to have any type of examination in the last 5 years because the ability with managed care is not available to have in-home procedures. So accessibility is pretty bad for any medical care.
Thank you. Another question that we have is, what are sources of confidence in your life?
I'm not sure I understand the question. If you're talking about like support, kind of like I talked about earlier, maybe.
So the question, I simplified it a little bit. The person who asked the question indicated their family loves them, but some of it comes from a place of fear about ambition in the career and what that ambition may do to deteriorate or impact their disability. So what are some sources of confidence in your life to overcome that?
Okay. So I had a lot of that too. My mother, because she was a single parent, was very protective of me, but she also listened to the folks that supported me at DuPont. Um, they were the folks that said, there's a lot of people with disabilities in the world doing a lot of really great things. And just because you have a physical limitation doesn't mean that you should limit your possibility with your future. So I had some really good people to support me and to teach me what it meant to be an advocate and how to advocate for myself and others. Today, I still work at a center for independent living. And I learned about the independent living movement and philosophy through that organization. I have my partner who supports what I do, has always been active himself in the disability rights community. So I think I've surrounded myself with a circle of people to support me and motivate me and kind of kick me in the butt when I feel like I'm not doing enough, and get me back on the right track. So I think it's important to make sure that you have a supportive environment that can encourage you and just kind of push you along when you need to be pushed.
Thank you for that. As somebody who has a non-visible disability and struggles with the disabled identity, what advice do you have for feeling less shame about it?
That's a hard one because there's a lot of people that have a non-visible disability, and they deal with the prejudice of folks not including them or not looking at them as being equal to somebody that has a physical disability. There is a hierarchy of disability, and we see it in our own community where, individuals will say, well, I might be physically disabled, but at least I'm not deaf, or I might be deaf, but at least I'm not blind. So we see that in our own community. It's very unfortunate. But what I would say to you is take pride in who you are and get out there. Show your stuff. Do not apologize for who you are, for the disability that you have, but own it. Own that disability and show people what you can do, and don't let anybody take that from you, because there is a wonderful community of people that will embrace you and welcome you, and understand the strength that you have just from overcoming the the knocks that are put in front of you.
Thank you for that. I think we can go ahead and continue with the presentation.
Great, thank you. All right, so let's talk about specific healthcare needs of people with disabilities. So really the healthcare needs are the same as everybody else. We need preventative medicine. We need screenings. We need to have the ability to have physical activity and have social interactions with others. In addition, though, people with disabilities typically require some specialized care for their different needs, for their different disabilities. And those cares do require accommodation. So health promotion and prevention activities seldom target people with disabilities. I talked about myself and the lack of some of the preventative care due to accommodations. Women with disabilities receive less screening for breast and cervical cancer than women without because examination tables are not height adjustable and the mammography equipment only accommodates women who are actually able to stand. People with intellectual impairments and diabetes are less likely to have their weight checked. Adolescents and adults with disabilities are typically excluded from sex education programs. Some of the barriers to healthcare is prohibitive costs, affordability of health services, transportation, the lack of appropriate services. And then we see that 51 to 53% of people with disabilities compared to 32 to 33% of people without disabilities are unable to afford health care. Other barriers are access to buildings, hospitals, health centers, clinics, inaccessible medical equipment, inaccessible exam rooms, poor signage. Now, what does that mean? Well, what about a person who has a visual impairment? If you're not going to assist them and guide them, how are they going to know where they need to go and what is located where? Not everybody has Braille signage. And if they do, not everybody can read Braille. If you have somebody with a hearing impairment, how are you going to communicate with them if you don't have an interpreter available for them? For someone in a wheelchair, the hallways are typically narrow, and so are the doorways. And bathroom facilities in most healthcare settings are not set up for people in wheelchairs. And then when we talk about actual ADA accommodations, that doesn't take into account a person who has dwarfism, a person who is smaller than an average height person. The requirements are for higher toilets, not for lower toilets. So there's a lot of discrimination and just inconsistency in what we say is accessible. Other barriers include getting to the appointment, getting into the clinic, checking in for your appointment. A lot of people need assistance writing, signing. Sometimes the counters are too high. We need help completing that paperwork. Again, getting through the clinic and the halls, and then just appropriate communication accommodations for everyone. So I told you earlier that I'm not unique in my disability. So I have a very brief video that I'd like to share with you that will kind of highlight that.
People with disabilities face unique challenges when accessing healthcare. As a quadriplegic and a woman with a disability, I've experienced some significant challenges in different healthcare settings. With like going to the ER, if I don't tell them how to treat me, they would just treat me like any other patient who walks into the ER, and it would hurt me more than help. Although patients' needs may differ, the quality of their care should not. There are many ways healthcare organizations and providers can improve quality of healthcare for people with disabilities. This may include making modifications to the approach and entrance to the healthcare facility and how patients navigate within the building and the provider's office. Some patients may require the use of accessible medical equipment, such as a mechanical lift or wheelchair accessible weight scale during their appointment. Going to any doctor's appointment or going anywhere in this world, it's not made for wheelchairs, or at least wasn't initially made for wheelchairs. There are out there accessible exam tables, and most providers do not have them. It's important because many elderly people can't step up and get onto the exam table. To provide accessible care, it's also important to ask questions to understand patients' needs.
One of the best ways for a doctor to really accommodate my needs is when they ask me questions, and they don't make an assumption of what I can and can't do.
My provider is a very good provider because first thing is that he cares and he asks questions. Visit our website to find resources and learn how you can make care more accessible for people with disabilities.
So for a lot of people, we face these same issues. So I wanted to make sure everybody got to see that and visit cms.gov's website. They have a lot of great resources. So I think I'm going to go on just a little bit, and then we'll take questions after when I get more toward the end. I just want to touch on this because I don't think a lot of people realize the impact that their home care situation has on them and their health care. So we are currently in a dire crisis for home care providers. And if you look at this can kind of give you an overview of how we value or do not value our home care providers. Currently, as of January 2021, the average annual pay for a fast food worker in the United States is $22,485. That breaks down to about $10.81 an hour. As of November of 2020, the average hourly pay of a home health aide in the United States is $10.68, and that's on the higher scale. So we don't value our home care providers any more than we value a fast food worker, even though every aspect of our life relies on them. This is a little bit more of a breakdown. An estimated 12 million people in the United States require long-term care. This is expected to climb to 27 million by 2050. This is before the pandemic. I don't even know what that'll look like now. A little snapshot of what home care supports. do to help us. They assist us with everything. Daily tasks such as eating, dressing, bathing, errands, household chores, skilled care such as bowel and bladder care, trach care, wound care, medications, and social supports to assist us in participating in the community. So why am I telling you this? Because it's important to remember what we go through just to get to an appointment to see you. When we go to see a healthcare professional, this is everything we need to deal with to do that. Scheduling our care, the caregiver dependability. What if they don't show up? What if I can't get out of bed? The amount of time for cares. The one thing I didn't tell you is that my cares in the morning take me 5 hours. 5 hours of just care. Then another hour to get into my wheelchair and positioned. And then if I'm going to a healthcare appointment that's not local, we're talking an hour and a half travel. So before you ever see me, I have 6 to 7 hours prior to prepare for that appointment. And that's hoping nothing goes wrong. The distance to the appointment and transportation, planning for procedures, the equipment needed, whether the procedure can be done, discussion regarding accommodations, telehealth. That sounds really easy, but there's a lot of people today that don't have technology to do the telehealth visits. Insurance coverage and prior authorization, and then appropriate care coverage after a procedure. So here are some more factors that play into the healthcare needs of people with disabilities. The ability to communicate their health needs effectively with their care provider. So again, somebody who's deaf, if there's not an interpreter, the information, there's going to be a disconnect between that person and that care provider. The ability to receive an appropriate and thorough examination with the appropriate equipment and spending significant time with people. Again, people's ability to process information and ask questions. After that appointment, some of the barriers are obtaining prescriptions, getting to therapy, making and keeping appointments, accessing groceries. That's huge, especially when individuals are dealing with issues because of malnutrition or inappropriate diet, and just participating in physical and social community activities. So this is a better breakdown. 1 in 3 adults with disabilities, 18 to 44 years, do not have a usual healthcare provider. 1 in 3 adults with disabilities, 18 to 44, have an unmet healthcare need because of cost in the past year. And 1 in 4 adults with disabilities, 45 to 65, did not have a routine checkup in the past year. 2 in 5 adults age 65 years and older have a disability. 1 in 4 women have a disability. Native Americans have the highest disability rate among working age adults. African Americans are second at 11%, Caucasians 9%, Hispanics 7%, Asians 4%, and more than 1/3 of the LGBTQ adults identify as having a disability. That is significant. So to be healthy, all individuals with or without disabilities must have opportunities to take part in meaningful daily activities that add to their growth, development, fulfillment, and community contribution. Until recently, people with disabilities have not been included in public health surveys, data analysis, or health reports, which is why a lot of people don't recognize disability as being such a broad area and such a large area. I'm just giving you a snapshot of a training we do. This is a training that was developed out of something that I saw at the Alfred I. DuPont Institute with their staff. We have a disability awareness training where people go through various exercises to experience what it's like to have these disabilities. So what can we do? Physicians can provide a broad range of modifications and adjustments, reasonable accommodations, change the physical layout of clinics to provide access to people with mobility difficulties, offer accommodations for communicating, offer accessible format, an alternative format, offer interpreters, offer in-home accommodations, promote community-based rehabilitation facilities to facilitate access for people with disabilities with existing conditions to have discussions. Integrate disability into education. Train community workers so they can play a role in healthcare services. Provide evidence-based guidelines for assessment. Identify groups that require alternative service delivery models. Include people with disabilities in your healthcare surveillance. Conduct more research on the needs, barriers, and healthcare outcomes for people with disabilities. In conclusion, we like to look at the disability paradigm that we have moved from segregation to a rehabilitation, charity and medical model to now a civil rights and social justice model. I will leave you with these 3 points to take with you. Please remember to listen to your patients, your community. Don't just hear them, but really listen. Remember to communicate clearly and educate. Don't assume that people cannot or will not understand. And always advocate. Advocate for your patient. Advocate for yourself. And this is the disability community. This is my community, the people that I fight with, the people I fight for. This is us. If there's any questions, I'd be happy to take them.
Thank you very much for the presentation, Maria. We do have a few more questions. I know that it is 5 o'clock, so anybody who is on the presentation who needs to leave, please go ahead and do so. This event was recorded, and we will provide a link to the recording for anybody who wants to catch up on anything that they missed. The questions that we have are, can you talk about or provide advice about employer alternatives that were made available as an accommodation, but were not an equal opportunity? And when is it appropriate to challenge those kinds of issues?
Well, I think that you need to have your needs met. In employment, you always have to look at what is the requirement of the job. Can I do that job as well as anybody else? If the accommodations are something that will make you equal to any other candidate for that job, then it's very appropriate to ask for those accommodations. There's a lot of programs that assist with employment placement, so that's always something good to look into because it could help with the accommodations and take some of the financial burden off of the employer. But definitely it's appropriate to ask for the accommodation to do the job that you are able to do.
Thank you. How do you find a doctor who listens, a doctor who doesn't just throw medication at a patient to try it?
That's an ongoing challenge. And as soon as I have that answer, I will tell you, because I am still looking. But really, it's just about being assertive about your needs, having that dialogue, and if you feel like it's just not the right provider for you, by all means, continue to look for one that better suits your needs.
And the final question is, are there any medical centers or organizations that serve as role models nationally or internationally in serving persons with disabilities?
I've been involved in so many things, so I think there's a lot of really good disability rights organizations like the National Council for Independent Living, ADAPT, which is Americans Disabled for Attendant Programs Today. Every state has a center for independent living, and they should be educating about disability rights and about the need for the community to change. In regards to medical centers or hospitals, I think that the Alfred I. DuPont Institute was fabulous. I believe it still is. I don't have as much connection with them, but most children's hospitals do a lot to really promote independence and advocate for their patients. Unfortunately, there aren't many hospitals for adults with disabilities that do the same thing.
Thank you very much. We really appreciate your time and the presentation that you provided to us.
Absolutely, thank you. And my information is on there, so if you have the PowerPoint, feel free to reach out to me at any time.